full 2 hours. Let me again remind you, I'm Amy Hughes. This is the first time I've really been able to talk with you as a group since your very first day. A little bit about myself. I have been a PA for 23 years, graduated from OU PA program, was a dietitian before that for 3 years. I worked with Dan and Amber back in the 90s at the OU PA program for a little bit. And then the last 13 years I've worked in the area of dermatology. So I have been in a more of a specialized area, so I'm still kind of, relearning some of the stuff I learned when I was in your seat. What else? I am married. I have one daughter. I'm very proud of her. She's a senior at McGinnis High School, Bishop McGinnis High School. I'm real proud of her. She got a golf scholarship. She just started playing golf as a freshman in high school, although she's a very good athlete. She did competitive gymnastics for years and years, and then got into cheerleading after that, and quit 2 years into cheerleading with when she started playing golf, and she got a scholarship to go play up in Kansas City Small College called Rockhurst University, small Catholic school. So I think it'll be a good fit for her. Big city feel, not New York or anything, but not a small town either, but yet a small campus, so I think it'll be good for her personality. I have a dog and a cat. I'm a huge animal lover, dogs probably especially. I love to read. I love to cook. I obviously love to eat what I cook. And so we have potlucks. I know you guys could smell that. I guess it was last week for our birthdays. I love to cook for those. So I hope everything went well through anatomy. I know you trial by fire, but you made it. Good job. On to the next. So this week we're talking about physical diagnosis. I'm going to concentrate on the history of present illness, or HPI, and the review of systems. These are the learning objectives. I'll just let you buzz through those. I'm just going to read this. The goal of the physical diagnosis concentration is for the student to obtain or to gain fundamental knowledge in performing a physical exam, learn how to recognize medical disorders, and effectively interview, examine, and record medical findings related to the patient. Students should gain an understanding of normal versus abnormal physical exam findings. The core value is to respect the patient while achieving competence and compassion. The skills that are learned through this course are what will build a trusting, fruitful relationship with future patients. These skills that you will utilize on a daily basis as a PA. As long as you guys are working as physician assistants, you will be doing histories and physicals. So this is the bread and butter of what you're going to do. These are some of the things that we're going to be talking about throughout this week. Again, I'm talking about today, right now, the HPI, history of present illness, and the review of systems. Just a little review of what to expect this week. We've got some of those lectures like I talked about. Wednesday morning, we're going to have you guys in small groups, and you guys will practice performing the vitals on each other. Blood pressure, respirations, heart rate, that sort of thing. That afternoon, we're going to have a standardized patient with a couple of you at a time, and you will practice getting that history from the patient. And you'll get instant feedback. One of us will be in the room, one of the faculty will be in the room, and we'll give you some feedback as you're doing that. We will have you write up your first little note about that history that you're going to obtain, and then Thursday afternoon, we'll meet with you one-on-one and again give you some feedback. And then all day Friday we're going to be working with standardized patients, but that will be 4th grade. A lot of memorization. Review systems, you're eventually going to have to memorize. And I think what's so important with the physical exam, none of us are experts, after a morning of practicing something. It's going to take months to years, and get your family members, examine on them. I remember back when I was in PA school, I would do all these examinations on my boyfriend at the time, now husband. So the more that you can do that, get your family members, anybody that has kids, examining kiddos are a little bit different than examining adults. So grab everyone. Okay, so we have two types of data. We have subjective data, and that's basically what we get from the patient as far as what they tell us. All right, that's going to be the history, what brings you in today. That's the subjective information. The objective information is what you actually see, what you actually touch, what you actually obtain. So your vitals, if you hear a murmur, that's objective data that you're going to document. Any lab data, imaging, radiography stuff, that's all objective. Okay, so when we're obtaining subjective information, objective information, we're going to compile all this information together. And for this particular patient, we're going to develop a number of diagnoses or conditions that could explain those symptoms that they're coming in with. Does that make sense? And that is what we call our differential diagnosis. Everybody, whether it's a cough, chest pain, hurt toe, whatever, you're going to come up with a number of differential diagnoses. And then with these differential diagnoses, then you test. They're almost like little hypotheses. Could these things be the explanation as to why this patient is presenting with what they're presenting with? And then you're going to test that. Okay? Not necessarily, obtaining blood tests every time, but you might. What's very important, you may not be able to come up with the exact diagnosis the very first time you see somebody, and I think that's something I had to struggle with because I felt like, oh my gosh, what exactly is this? You don't always have to have the exact proper diagnosis for the very first time you see someone, because oftentimes their presentation will change over a period of time. The big thing is that you don't miss big things that can be life-threatening. Diagnostic tests, we may order to test some of those differential diagnoses. The reason why we do tests or obtain x-rays or whatever is to help solidify what we see on exam and what we're getting from their history. We don't want to just obtain lab work just because, for a number of reasons. One, it's expensive for the patient. You always have to consider the cost for patients. And then number two, you don't just obtain blood work just for curiosity. All right, so our steps, we're going to take the history. We're trying to get what symptoms are bringing them in there and the timeline, when it started. We'll talk more about this. And you're going to begin that problem list. Then you're going to develop hypotheses. You're going to think about, okay, what could explain if you have chest pain, a person's complaining of chest pain, what are all the different things that can cause chest pain? The pulmonary system can cause chest pain, the cardiac system can cause chest pain, musculoskeletal. You have to think about all those things. Then you're going to try to get some objective information. You're going to do a physical exam on this person and see what correlates with what you're finding. You're going to form that problem list and then the differential diagnosis. You're going to test those, whether it's actual lab tests. You may need to modify. If you find something on your the objective data that you obtain via lab or x-ray, you may need to change that differential or move one differential up and lower the other. And eventually, when you feel confident that you've come up with an explanation, then that's going to be your diagnosis. All right, so the history component, the subjective information, includes chief complaint / chief concern, HPI, history of present illness, past medical history, past surgical history, medications, allergies and what kind of reactions they have to these medications, social history, including a number of things, family history, and the review of systems, which we'll talk more about. The history, really and truly, is one of the most important things that you can do. First of all, it's your very first interaction with the patient, so you can establish a very good relationship of trust from the get-go. You need to obtain as much information as you can, and again, the more you do this, the better you will become at it. You know, you just have to do it. So the value of your history that you obtain is very much dependent upon the ability to get relevant information. Talking about the chief complaint, and again, we'll talk about that. They may come in with chest pain, but we need to also, thinking about the patient, find out how does this chest pain make you feel? What makes you concerned about that chest pain? Put it more on a human level rather than patient A with chest pain. We want to interact or connect with these patients. You know, you always need to be aware of nonverbal communication. You know, this kind of business all across. You just need to, and again, you will be able to interpret that better. You need to be a good listener. You don't always want to be the one asking the questions. You need to listen. So about 70% of your diagnoses, can be made on the history alone. Okay, so that indicates how important that is. 90% of your diagnoses can be made based on the history plus the physical. So that's pretty important. Again, not so much the lab and the x-rays and things like that. Those are more to confirm what your suspicions are. All right, so you want to set the stage for a good interview or history obtaining. You always want to welcome the patient. First thing you're going to do when you walk in the room is to wash your hands. You're going to, I know, I'm not used to doing Professor blah, blah, blah. Professor Rourke gave you a good right and wrong display of what to do. So wash your hands, or knock first. I always like to, I think that's a nice thing to do. Clean your hands, ask how the patient would like to be addressed. I personally feel that, especially if someone is older than you, you assume it's a Mr. or Mrs. or something like that, rather than by their first name. That's kind of a pet peeve of mine. Identify yourself, introduce yourself. I think extending your hand is a good thing, or at least touching somehow. Identify who you are. My name is blah, blah, blah. I'm a PA student from OCU. I'm going to be taking care of you today. Close the door. Make sure you have privacy. You don't want everybody out in the hallway knowing what you're talking about. And just make it comfortable. Try to put the patient at ease. At first, you guys are going to be the nervous ones, but you'll get over that. Try to, I always try to sit down with the patient, be more on an eye level with them. I don't like to be above them, when they're as much as you can. Say a person's in the hospital setting, maybe try to raise the head of their bed up so you're not, looking down at them. That can be awfully intimidating. I was kind of tired. Don't be looking at your watch like Miss Sally was with the bad display. Always make good eye contact, that's important. Be aware of a patient's personal space. There are some people who just don't know that and they encroach too closely, but be aware of that. And also know that these people, most of the time, are sick, especially if they're in the hospital. They're going to tire easily, so you may need to cut your interview short and say, I can tell you are getting pretty tired. Why don't we call it a day for right now, and I'll come back in a couple of hours. Certain types of questions. We have open-ended questions. You're always going to start your interview out with an open-ended question. That allows the most ability for the patient to give you a bunch of information. Closed-ended questions are just basically where you expect a yes or no answer. Do you smoke? Have you had a fever? Things like that. Where an open-ended is more, tell me why you're coming in today. How can I help you? Things like that. Again, direct questions, much like the closed-ended, you just want specific information. You want to really avoid leading questions. Leading questions is kind of where you're planting an idea of what that answer should be in the patient's head. So it'd be like, you don't smoke, do you? Well, of course they're going to say, absolutely not, I would never think about smoking. Okay, so let's talk about the chief complaint. The chief complaint is the patient's reason for presenting to the patient in their own words. That's incredibly important. When you document the chief complaint in the chart or EMR, you're going to document that in their words in quotation marks. Okay? I have an example down there. I've had a bad headache for about a week. You're going to write exactly what they say. So, open-ended. What brings you in here today? How can I help you? I see that the nurse wrote down you're having a headache. Tell me more about that. All right, so the HPI, history of present illness, the chief complaint is kind of like a springboard. That's what our target is. Then we ask a bunch of other questions to try to find out more additional information, so then you can start developing that differential diagnosis. Open-ended questions are better, especially at first. So headaches are the big problem. Tell me more about this. You always want to make eye contact, encourage that talking. Let them know you're listening. You know, or nod your head, things like that. Encourage that communication. When we're talking about the HPI, we oftentimes use the Big 8, all right? And you're going to have to memorize these. This is what you're going to be asking. Now, the Big 8 doesn't necessarily work with every single complaint, but it's a good starting point, all right? So we'll talk more about every one of these. So body location. You want to find out where their problem is occurring. If it's radiating, can you tell me or point to where the area of your pain is? Where in your back do you feel the pain? Does the pain radiate anywhere? Okay, that's telling us the body location. The quality, description as to how the symptoms feel to the patient. Can you describe the pain to me? What do you mean by a sticking pain? Okay. Bless you. Quantity is where they're going to kind of scale how badly, put a value point system, so to speak, to a symptom. So on a scale from 1 to 10, with 10 being the worst pain you've ever experienced, how would you rate your pain? Okay, this is a quantity or severity question. What do you mean by a lot? So actually, how many times did you vomit? Or for a female, how many pads have you had to use over a 24-hour period? They're quantifying. Chronology, this is the duration and timing, the order of how these symptoms progressed. So when did you first notice it? How long did it last? Are you still experiencing it? Is the problem getting worse, getting better, about the same? The setting, this is how and when these symptoms started. What were you doing when you first noticed this pain? Does your chest pain ever occur at rest, or is it just when you exert yourself? Do you feel this chest pain anytime that you do a certain activity? Okay, these are questions about the setting. Aggravating factors. What makes your pain worse? Does it seem to occur at any particular time of the day, around meals or after meals? And alleviating factors, anything to make it better? Does it relieve, or does it calm down when you sit and rest for a bit? Does your headache get better when you go sit in a dark, quiet room? And any associated symptoms? Are there any other symptoms that are associated with the primary complaint? Is there a headache associated with your fever and sore throat? Do you have nausea with your pain? Things like that. Anything else occurring at the same time? When you're interviewing, you always want to avoid talking above their head. You know, bring it down on their level. Use terminology that they're going to be able to understand. Medicine has lots and lots of complicated words, and each specialty area really has their big words. So keep it to words that they will understand. You don't want to use, you have dyspnea. They're going to be like, oh my God, I hope not. So, do you feel short of breath with that? If you have, which you will run into, especially when we get over, start working in the Good Shepherd Clinic, use an interpreter if you can, because it's hard to communicate with someone that is speaking a different language than you. And we've already kind of talked about this. These are certain things that we can do to encourage that interaction, facilitation. You're just encouraging your patient to say more. Let them know that you're listening to them. Nod your head. Say, I'm listening to you. Reflection is when you may repeat what you heard to encourage more detail. So the pain got worse and spread and began to spread. It spread? Like, tell me more about how did it spread? Where did it spread to? You may need to clarify something. If you have a difficult time understanding exactly what they're saying. What do you mean? What do you mean by that? What do you mean by it lasted a minute? I'll never forget back when, this was a number of years ago, when a minute was kind of became popular jargon, and I thought it was a short period of time, and so I had to clarify. Well, I learned that it actually means a pretty long period of time, so I educated myself there. All right, so empathetic response. You know, if the patient is showing grief or pain or something like that, let them know you're connecting with them. I understand. I'm so sorry. Nonverbal, you know, reaching out to them, touching their arm or leg, handing them a tissue if they are crying. I've done that a lot. Confrontation is not really where you're, you know, aggressively confronting somebody, but it's just a response that points out to the patient something about their own words or behavior, such as, you look upset. Tell me why you're upset. Or You sound very uncomfortable about that. Interpretation is similar to this, but it's based on something you are inferring. So nothing has been right for you today. You seem very upset with the hospital. Tell me more about that. You seem to be asking a lot of questions about x-rays. Are you worried about x-rays? You don't know for sure, but you want to solidify that what you're inferring is accurate, because it may be dead wrong. When obtaining histories, there's going to be a time that there's going to be some sensitive material you have to ask about. Makes everybody in the room a little uncomfortable. But the more direct and to the point that you can be, you don't need to apologize for anything. This is your job. You're being trained for this, and it's going to help you to be a better provider, knowing this information. You certainly don't want to preach about anything. You're not there to pass judgment on them. You're just there to get the information and to help them. Okay, so let's talk about any questions. Okay, do you guys have anything you want to add to? Okay, do it.
You're doing great.
Okay, so the review systems. This is where we have a list of questions arranged by organ systems that is designed to uncover potential disease or dysfunction with that system. We oftentimes will use that. I have 3 bullet points. We oftentimes will use that to better define the likely cause of your presenting symptom. In other words, trying to develop your differential diagnosis. So, if a person comes in with chest pain, you're going to ask your Big 8 and get information like that, but then you're going to go to your review of systems in the cardiovascular system, in the pulmonary system, and you're going to ask those review of systems again to get more information, trying to develop that differential. Now, you oftentimes, if you have a brand new patient in your practice, you may, in order to get to know them for the first time, you may use a big, long review of systems as kind of a screening tool. Make sure you're not missing anything big. Sometimes people don't want to come right out and say, I'm having chest pain occasionally. So this is a good way to uncover some of these things. Now, when you're moving from the HPI to the review of systems, you're going to want, we always want you to concentrate on, what's the term we use? Introductory? Transition statements, thank you. I'm transitioning, you're not going to say that to the patient, I'm transitioning now from the history to the review of systems, but you're going to kind of lead them that way, to explain what you're doing. With this, you may need to say, I need to ask you a number of questions. I'm sorry, I lost my train of thought here. Of some symptoms that you may or may not have. So we don't miss anything. Say yes only to the symptoms, and you may want to quantify. You may want to say, in the last 6 months, let me know if you've experienced any of these symptoms. And it's meant to go pretty quickly. I mean, you could spend, a long period of time. So, and then if you ever have one that is significant, such as chest pain or something like that, then you're going to go back, possibly, to your Big 8 and ask the Big 8 on that particular symptom. Does that make sense? Okay. So these responses of yay or nay, positives or negatives, you have to kind of interpret, again, like what I was saying. Is chest pain in an 18-year-old versus a 65-year-old are way different. So you need to individualize for each patient, think about what risk factors they may have, and if you need to obtain more information on that positive review of system, then go back to your Big 8. Okay? As far as this week, the only review of systems that you guys will be obtaining is the general, okay? We will concentrate more of each review system when we're learning about that, in that module, cardiovascular system. You're gonna have to, or HENT, I'll start with that one. HENT, you're gonna have to memorize the review systems for the head, eyes, ears, nose, throat, okay? I'm not gonna sit here and read through all of these, you certainly can. And I think another thing that's important to mention is you may document it, say they reported positive tinnitus. Well, you're not gonna say, are you having tinnitus to the patient? You're experiencing ringing in your ears, okay? And as far as the physical exam, again, this week, we're going to concentrate on just obtaining the vitals. And then when we get into HENT section, we're going to learn the physical exam component for the HENT system. When we get into cardiovascular, we're going to learn the cardiovascular exam, etc. Again, I'm not going to go through all these. We'll talk more about them in each section. I think that's it.
You'll also be learning the review of systems that are pertaining to that
Exactly.
area as well.
Exactly.
And that's where your review of systems will come in. And not only will it be that one body system, but there may be something that indirectly may relate that will also fit on. So you'll be learning those in bits and pieces because there's an awful lot of questions in your review systems, and we won't expect you to know it immediately.
Yeah, you might start reviewing them because you will have to have them from memory. Just something you need to know from here on out. Any questions? Yes, sir.
Are there any questions?
I'm sorry. Yes, sir.
Do we have 10 minutes?
Yeah. Are you talking after me?
No. But I would like to do an exercise if they're up for it.
Absolutely.
So, everybody, the whole class needs to split off in groups of 2. Groups of 2.
How's going? Excellent. So, do you want me to get it or you?
Groups of 2. Everybody have a partner? Who does not have a partner? So you need to get out and move somewhere where you can get some. What?
Oh, yeah, we have 35.
Oh. Then, so Amy will join whoever doesn't have a partner. You don't have a partner?
Or the
Group of 3?
Yeah.
Or group of 2.
Okay, so what you just heard Professor Hughes say is that the history of present illness is really important. It's literally the most important diagnostic information you're going to get. 70% of the time, the diagnosis is in there. The problem with this is that the patient's the only one that knows what's going on. We know all this stuff, and we're really anxious to talk about it, but the patient's the only one that knows. Okay. So, everybody have a partner? One of you is going to be the interviewer, and one of you is going to be the interviewee. Figure out who that is.
Okay.
Okay, now, there's only one question. What we want to do, it's not only one question. The interviewer is interested in finding out what the interviewee did on their last vacation. So the interviewer, if you have a pen or if you have a computer, write some notes about what questions you asked. The interviewer, what questions did you ask? And we will take 5 minutes to do this interview. You're trying to figure out what the interviewee did on their last vacation?
That's building, I'm Greg Paula. That's pretty expensive. What are we here for today?
Okay, so what did you do on your last vacation?
Oh, your vacation, where'd you go? Dominican Republic, excellent.
And,
What did you do? Activities. Well, I'll just go take the local fauna. Have a good fair sailing?
That's why I was like,
Makes sense how you like You try to do things like that? Anything that you found particularly right. Oh, that sounds like a beautiful place. Nice. Yeah, do you have any of those food stands? Nope. That makes sense. When did you go? We'll call it 18 months. More 10? Hey. Silver lining there. Sounds like you achieved it fairly well.
But we're practicing medicine in a time crunch these days, and so you don't have very much time with your patient. What we want to demonstrate is how much information you got. So I want to see the hands of all the interviewers. Okay, I want to get maybe 3 or 4, look at your list and tell me how many questions did you ask?
Oh man, I didn't write them all down, but.
Give me an estimate.
10, 15?
10,
8.
8? Anybody ask more than 8 to 16? Okay, it's about 3 minutes. Does anyone in the room think that they know precisely what happened on this last vacation? You got a pretty good idea.
Well, she does.
Professor Rourke was going to demonstrate what you just heard Professor Hughes tell you, but it didn't quite sink in. So we're going to try to prevent you getting too much enhancing feedback on Wednesday. Okay?
Tell me about your most recent vacation.
Oh my God! I had a vacation last summer, and I I got my family together, my 2 sons, my wife. We loaded our bicycles on the top of our car. We went to the Missouri Valley on the west coast of Iowa. And we rode our bikes 500 miles across the state of Iowa. 500 miles. I mean, it was awesome. My youngest was 10, my oldest was 13. My wife had never exercised in her life. She got ready for this. And we every day we had, it was like 10,000 people in this bike ride. It's a party every day. At night we would camp out. We would eat at churches in these small towns in Iowa. It was, the hills were apart. One day, my 10-year-old, it was 70 degrees, it was 103 degrees, 70 miles. Middle of the afternoon, my son looked at me and said, "Dad, I thought you said it was flat tonight." He said, "What?" I've never been to Iowa. I said, "It looked flat to me from the airplane." he said, "I'm never believing another thing you tell me." That's what we do.
That sounds very fun. Where did you end up?
At the Mississippi River on the east side of Iowa. Iowa's got a river on either side.
How long did it take you?
7 days.
And everyone made it?
Everyone made it.
No injuries?
One morning we woke up and my 10-year-old, he and I were sleeping in a tent, and it had rained the night before, and our air mattresses were kind of floating, and he said, "Dad, do I have to ride today?" And I said, "No, you don't have to ride today. There's a bus you can get on, they'll take your bike, and we'll just see you." He said, "Is this the 100-mile day?" I said, "It is." He said, "That's a century." I said, "Yes, it is." He said, "If I ride it, do I get a patch that says I rode the century?" I said, "Yes, you do." And 13 hours later, we pulled into the next town.
Wow. And you said summertime, but what month was it?
July.
It was very hot. That's good. Sounds like a great vacation.
What's the difference?
She let
You want to ask two questions.
What?
She asked a few questions.
How many questions did she ask?
About more questions.
4. And the first one, which one got the most information?
Tell me about your most recent.
Because it was completely open-ended. Tell me about the vacation. And then what did she do? She let me talk. I'm the only one in the room that knows what my last vacation was. This one wasn't my last vacation. This one was about 35 years ago. Yeah, that 10-year-old is now 43. 33 years ago. But you can tell by looking at me. I didn't have 10 years. Okay, so what is going on here? Why did you guys do up to 16 questions and she did 1? What's going on?
You focused on details.
Do what?
If the patient didn't or wouldn't elaborate as much as you did, to kind of keep it prompted, to keep them talking.
Okay, so here's the data. That might be true. Not very common. But it might be true, and sometimes it is. The patient just won't talk. The data are that audio recorders have been placed in physician offices. I don't know about PAs, but physician offices, to find out how long the patient gets to talk in a medical interview before they get interrupted by the physician. First time this was done was about 1983, and it was 7 seconds. A group got together nationwide and educated faculty members at medical schools to try to teach medical interviewing all across the country. And 10 years later, it really worked. But 10 years later, we did the study to see how the physicians are doing now. And the outcome was 11 seconds. What's going on? Why do these providers insist on interrupting the patient? She had a lot of questions she wanted to know about my story. What month was it exactly? Did you make it all the way? Exactly. So there are some exactly things that I wasn't telling her that she needed to know. And she waited until I got through with my story. because the diagnosis is in my story. Why do these providers, 35 of whom are sitting in the room, want to interrupt the patient so quickly?
I focus too much on myself
Why are you so focused on yourself?
because I'm too anxious. I don't want to miss any information. I want to get as much as possible.
Because you're anxious.
Anxious. I don't want to miss it.
You don't want to miss anything.
Because you're the hero,
Yes.
not the helper.
You're the hero of the story. I mean, isn't it worth something that I sat in that damn classroom 8 hours a day for a year? I learned all the anatomy, I learned all that stuff, all those drugs. I'll just show them how much I learned. I'm as guilty as the next guy. I got a bad disease one time and I came home, I told my wife the results of the tests, and she started asking me questions, 5, 6, 7 questions, and I got irritated. I said, God damn it, if you want me to doctor, go to medical school. Not good for a marriage. But that's basically what we're doing when we interrupt a patient. You want to know about this, you go to PA school. It's the patient that's the only one that really knows what's going on. So as you enter Wednesday, think to yourself, open-ended questions. Keep it open. The other metaphor I use is let the patient drive the train. This is another way of not being the hero. You shouldn't be driving the train. The patient should be driving the train. You should just be watching out the windows and finding out where we're going. Okay. That's all.
I think Friday we're driving the bus, but
The patient driving the bus.
just to make sure you don't let them go off the edge of the cliff. You have to keep them on.
I was dean of medical school for 6 years, and I used to have a recurring dream. Literally, I had this recurring dream. I'll just give you some history. I had this recurring dream that I was driving a bus full of people, and I drove it off the cliff every time. And I'd wake up startled in the middle of the night. I'd come to work, and I'd meet with my associate dean, and say, well, I drove the bus off the cliff again. Okay. What's up next?
Right?
Break, for sure, yeah.
Okay, great.
I have to fix my DEA number. How do you do it?
Wait, yeah, I want to fix my.
Wait, what do you do?
I guess. I don't know. I did it. Like, did it.
Wait, you redid yours?
I mean, like, I was just getting
I didn't either.
I don't think she's going to, honestly.
Wait, no, like, it turned out so nice.
Yeah, I didn't do that.
She did it on my iPad.
Ooh, that's a good idea. Yeah. I like how, like, dark it is.
And if I mess up, I can erase it.
Yeah, it's like,
I like it.
yeah, it's not.
I like it better.
I need to save mine too. Goodbye, friends.
I need to figure out how to do these.
Yeah, my
No,
I can try to. Yeah, I think we're in
I've seen it
It's like right here. Oh, yeah.
So I just put it on this box and it just works.
Yeah, because I tried to implement it in PowerPoint for my iPad for Wikipedia. I wonder if I can share my Google Drive with you. Actually, it's kind of a disaster. I don't want to open it.
Oh, wow.
I wonder if I can create a new folder. I know, I just can't get myself to do it because I have like my beautiful ears.
I just.
False alarm.
Yeah, I just put number.
That's what I
Yeah, me too.
The reason I did it was because I don't know. Oh, okay. Okay, I'm
Because I until okay, well, I made and making
Okay, see, I didn't know what they were, right? She's right.
so I'll ask her. I'll let you know, but I know for sure that she for sure needs objectives because I asked her and remember and I was like, I know this week you're
Oh, man.
like coordinating a lot of it last week.
You came prepared.
She's like only knows objectives.